Clinical Case Report by Kras, Nursing 6435, Pediatrics, May 17, 2021. The Chief Complaint. A 5-year-old boy presents to your clinic with a one-day history of refusing to use his left arm. History of present illness. The sole source of information is from the father. He states that his son and his older sister were cared for by a babysitter the previous day. The babysitter said she had been playing with the children in the front yard when their patient ran after a ball that was rolling towards the street. The babysitter grabbed the patient's left forearm and pulled him away from the street. Thereafter, the patient was irritable and holding his left arm close to his body with the elbow in a flexed position. Medical history. The father denies any history of relevant medical history. Medication list. The patient is not taking any prescription or over-the-counter medications. Family medical history summary. The patient's father denies any relevant or significant family medical history. Social history. The patient is the youngest of 2 children. He is in kindergarten and doing well in school. Father denies any history of smoking or use of illicit substances in their home. Review of systems. General. There are no concerns of weight loss or gain, fever, but the child is irritable and has recent changes in activity level due to immobility of the left arm. Skin. There is no history of rashes, eczema, excessive bruising, or skin lesions. Eyes. There is no complaint of discharge or pain, excessive tearing, or itchiness. Ears. There is no problem with hearing, ear pain, or drainage. Nose. No complaints of runny nose or congestion. Mouth and throat. There are no complaints of difficulty swallowing or chewing. Cardiac. There is no complaint of excessive sweating, activity intolerance, or a history of murmur. Respiratory. There is no history of cough, wheezing, or shortness of breath. Gastrointestinal. There are no complaints of abdominal pain, nausea, vomiting, diarrhea, or constipation. Genitourinary. There are no complaints of urinary frequency, dysuria, hematuria, discharge, or polyuria. Review of systems continued. Musculoskeletal. Denies complaints of myalgia or arthalgia, but there is trauma to the left arm times 1 day, and the patient is hesitant to move their left arm. Neurologic. There are no syncope, paralysis, ataxia. No change in bowel or bladder control. Psychiatric. There are no complaints of difficulty sleeping or hyperactivity, but the patient is irritable times 1 day. Heme, lymph, and endo. There are no complaints of fatigue, swollen lymph nodes, bruising, bleeding, intolerance to heat or cold, increased thirst or hunger, or changes in urination. Physical exam findings. Weight of 40.5 pounds, height of 43.0 inches, blood pressure of 110/76, heart rate of 100 beats per minute, and a temperature of 98.6 degrees Fahrenheit. Physical exam findings. General appearance. We have a well-nourished 5-year-old in apparent discomfort with favoring of the left arm. The skin is appropriate to race and ethnicity. There are no evidence of rash, nevi, or birthmarks. The head is normocephalic, atraumatic, with evenly dispersed hair. Eyes, perla with extraocular movements intact, no discharge, conjunctivitis, or scleral icterus, no ptosis, and we see positive red reflexes bilaterally. Ears, we have clear external auditory canals, tympanic membrane pearlescent without redness or bulging, pinnae normal shape and contour. The nose, normal pink mucosa, no discharge or blood visible, normal midline septum. The mouth, moist mucous membranes, with 20 primary teeth visible without evidence of dental caries. The neck is grossly non-swollen, negative ventricular deviation, lymphadenopathy, goiter, or mass. Chest, we have Tanner development stage 1. Lungs are clear to auscultation bilaterally, no evidence of intercostal retractions. Physical exam continued. Cardiovascular, we have a quiet precordium, no right ventricular heave, no thrills. The point of maximal impulse is in the left midsternal clavicular line in the 6th intercostal space. Regular rate and rhythm, normal S1, S2. No murmurs, gallops, or rubs, and then +2 pulses in all extremities, including a strong bilateral femoral pulse. Capillary refill is less than 2 seconds. The abdomen is soft and non-tender, non-distended. Bowel sounds present. Liver edge palpable 1 centimeter below the costal margin, and the scratch test reveals a normal-sized liver at about 5 centimeters. No noted splenomegaly or masses. The male genitalia, the exam was deferred. Musculoskeletal. All extremities examined are without gross deformity. However, the left forearm was assessed more in depth and was shown without bony tenderness, erythema, or swelling of the joints, but on passive motion the child resists any movement and cried in pain. Neurological, patient moves all other extremities symmetrically, normal tone and reflexes, and the cranial nerves were intact. Lab diagnostic exam results. There was an x-ray of the left arm elbow, which did show a subluxation of the radial head. However, with this particular diagnosis, we can do this without imaging, as this is considered a clinical diagnosis, meaning a diagnosis made in clinic. The diagnosis that I arrived at was subluxation of the left radial head, which is ICD-10 S53.002. In the pediatric population, radial subluxation is often related to high force trauma. It occurs due to an axial force on the pronated arm, which causes an annular ligament to slip over the radial head. This could either be due to a laxity or tear in the ligament due to trauma. The other name for radial subluxation is often termed the nursemaid's elbow. Differential diagnosis of 1 would be considered an annual ligament tear. The annular ligament covers the radial head and is weaker in children, which causes it to tear easily. When it does tear, pain occurs with motion, thus causing the child to hold their arm close to their body. They may even point to the pain, which could lead us to a buccal fracture diagnosis. Supracondylar fracture would be differential diagnosis number 2. This type of fracture is an injury to the humerus just above the joint of the elbow. The highest frequency of this fracture is amongst the pediatric population and is typically sustained due to a fall on an outstretched elbow or a direct impact to the elbow. The third diagnosis would be the olecranon fracture, ICD-10 S52.023b. A fracture at this point on the elbow occurs at the pointy end due to a direct impact or trauma. Symptoms include pain, tenderness, and swelling, as well as pain or an inability to straighten the elbow. Risk factors for radial subluxation include number 1, trauma. Trauma is the main risk factor for radial subluxation and can include either a force exerted on the elbow joint fractures or a tear in the tendon. The other risk factors are congenital disorders that are asymptomatic and can include Ehlers-Danlos syndrome, nail patella syndrome, ulnar dysplasia, radial ulnar synostosis, and dyschondroplasia. Signs and symptoms of nursemaid's elbow include immediate pain after injury. This is shortly followed by a refusal to move that affected arm. And then this child also often holds their arm in a very protective manner against their body, slightly bent, with the forearm turned with the thumb towards the body. The initial pain may resolve, and the child may return to some activities, but they will continue to refuse to use the affected arm. The National Clinic guidelines that I used was from Up to Date, and the article was Radial Head Subluxation, Pulled Elbow, Evaluation and Management. The treatment of the radial subluxation from this article included reduction of the joint, which can be completed in clinic. We begin by having the child in the parent's arm with the affected arm on the outside. We hold the child's wrist and then supinate the palm. We place pressure near the top of the radius with the thumb, and then we slowly extend, then flex the elbow until we hear a faint pop or click. We repeat the extension and flexion a few times to know that the arm and the bone is back where it needs to be. We can then prescribe ibuprofen 5 to 10 milligrams per kilogram every 6 hours for pain relief. To teach and health promotion, to prevent injury or re-injury, we will require education on how to prevent subluxation of the radial joint. Prevention will require education to not abruptly pull on the child's hand or wrist, to not swing by their hands or wrists, to not pull a child by their hand or wrist while they are pulling in the opposite direction. And of course, we want to lift the child by their armpits. Follow-up should be able to, before discharge, the child should be able to move their affected arm following the reduction of the radial head. If the pain persists, or if the child continues to favor the arm and not use it, the child should return to clinic for advanced imaging to rule out fracture or associated structures or tear of the tendon. References. Thank you so much for listening to my presentation. I hope you've enjoyed it.